Thank you, Dr. Bagley. Our next speaker is Ted Park. He's an addiction psychiatrist, also doing a NIDA-funded K Award. He's an assistant professor of psychiatry at BUSM, and he's going to be talking about benzodiazepine use in opioid agonist treatment, the risks and the benefits.
All right. Thank you so much for letting me talk today. I'm going to be talking about the topic of my K23 award from NIDA, benzodiazepine prescribing in opioid agonist therapies. I'd like to first just acknowledge my mentorship team, my research team, and NIDA for funding this research. And I realized that I somehow left Jeffrey Samet off the mentorship team, and he's looking right at me. You're on the slide in spirit. So I wanted to start by talking about my first patient as a psychiatric resident in Pittsburgh. He was someone who was taking large quantities of benzodiazepines combined with methadone maintenance treatment. And I remember him being miserable. He spoke about how embarrassed he felt after taking the drug combination because he knew he looked foolish in front of other people. And I think many of you know what he looked like while he was intoxicated, because this is something we often see people like this right around our own hospital. As one patient put it, it looks like you're going to fall down, but somehow you don't. So I learned in my training that you don't prescribe benzodiazepines for this patient population, because I didn't believe they could take the medication responsibly. There wasn't a debate. So when I started working in Boston, several years later, I was working in a methadone clinic, and I was really shocked to find that the majority of patients were being prescribed benzodiazepines. And I was writing these prescriptions, and I was regularly wondering, like, what am I doing? Why am I giving potentially harmful medications to patients? And there's an essential tension there, a feeling of discomfort that comes with prescribing controlled substances. Am I harming the patient? Am I helping the patient? Sometimes you don't know. Now, I used to think that it was best not to prescribe. So on this spectrum of benzodiazepine prescribing attitudes, I was very much a conservative. But my attitude has changed over time, and I've become more liberal with my prescribing. And through the research we've been conducting, I wanted to share with you the story of why my thinking has evolved. So this is from a recent New England Journal of Medicine Perspectives article that calls overprescribing of benzodiazepines as our other prescription drug problem. And it lays out the case for what might be called a benzodiazepine epidemic. And there is evidence for a benzodiazepine problem in this country. Deaths that involve benzodiazepines have been increasing over time. Deaths increased 9-fold between 1999 and 2015. And part of the reason deaths involving benzodiazepines have been increasing is that most of these deaths also involved opioids. Benzodiazepines are the most common other pharmaceutical drug involved in opioid analgesic deaths, and benzodiazepines can increase the respiratory depression caused by opioids. This is from a study we conducted in the VA that found that benzodiazepine prescription in patients receiving opioid analgesics was associated with an increased risk of overdose death. They were almost 4 times more likely to overdose. And that risk increased as the benzodiazepine dose increased, suggesting that benzodiazepines played a role in their deaths. And benzodiazepine use has been associated with overdose in patients receiving methadone maintenance treatment. There have been a couple studies from the UK that have shown this association. So if benzodiazepines are so risky, why do we continue? Why do we continue to prescribe them in opioid agonist therapy? This is from a study we conducted that found regional variation in benzodiazepine prescribing in both methadone and buprenorphine, up to 39% in buprenorphine and 24% in methadone, and that the variation in practice may reflect prescriber uncertainty. But why are prescribers uncertain if benzodiazepines are so risky? So one reason may be that benzodiazepines are an efficacious treatment for anxiety. This is from a meta-analysis of benzodiazepines for anxiety. These studies excluded substance use disorder patients, and benzodiazepines are among the more effective treatments in reducing anxiety. And anxiety has been associated with relapse and poor treatment outcomes in substance use disorders. So one study found a 5-fold increase of readmission for alcohol treatment for those with anxiety, and another study found that anxiety is associated with worse addiction treatment outcomes. And benzodiazepines have been found to be associated with increased methadone treatment retention. This is one study from a London clinic. And in our own buprenorphine clinic in the Department of Psychiatry, one of our fellows, Cristina Montalvo, conducted a study that found that benzodiazepine prescription positively predicted 1-year buprenorphine treatment retention. So the potential benefits of improving treatment retention is potentially great because we know that treatment with opioid agonist therapy is effective and can save lives. So there are both potential risks and benefits of prescribing a benzodiazepine to someone receiving opioid agonist therapy. On the one hand, it might increase their risk of death and lead to addiction to the benzodiazepine, but on the other hand, it might effectively treat their anxiety, which might actually help prevent drug relapse, and it might improve treatment retention in opioid agonist therapy. And it's this difficulty weighing of risks and benefits that give a lot of providers headaches. Am I going to help or am I going to harm this patient by prescribing a benzo? And in order to learn more about this, we asked patients themselves about their benzodiazepine use. So I'm going to describe a qualitative study of benzodiazepine users in opioid agonist therapy. The study asked the following research questions. Among patients who receive opioid agonist therapy and have used benzodiazepines, what are the motivations for benzodiazepine use? What is the patient understanding of the risks and benefits of benzodiazepine use? And what are the barriers and facilitators for discontinuing benzodiazepine use? So this is an ongoing study. We have 18 participant interviews that have been transcribed and analyzed. We included adults receiving opioid agonist therapy who have regularly used benzodiazepines, currently or in the past, and speak English. We used purposive sampling from an office-based buprenorphine clinic and a methadone clinic. Interviews were conducted and transcribed by myself and 2 research assistants. And the interview guide was a semi-structured interview based on prior topic areas. In terms of analysis, all of our transcriptions were reviewed by myself and entered into NVivo, which is a qualitative data software program. And data analysis was largely guided by thematic analysis. We used open coding by myself and 1 research assistant to develop a code book. And after we coded all the interviews, we identified major themes and relationships between them. So the study sample, as I said, consisted of 18 people. The median age was 41 years old. We had 11 females and 7 males. 11 were receiving methadone, 7 receiving buprenorphine, and the median length of time on opioid agonist therapy was 5 years. So probably the most common cited motivation for using benzodiazepines was to feel calmer. Without the benzos, I feel like I had a lot more panic attacks. I had a lot more going on in my head, and I felt like I couldn't get my head to stop racing. So I would say that I was a lot more pent up and fearful, I guess, when I wasn't on the benzos. Another common motivation to use benzodiazepines was to get high. When I got on methadone, yes, definitely because I didn't know that when you take a benzo on methadone, you get this high feeling because they say it's like twice as much as you take. So if you take 1 Klonopin, it has the effect of 2. So yeah, in the beginning, definitely. I definitely took them to get that high feeling and get a head change. Now, a common consequence was oversedation. When I overdo them, I'm falling asleep on the train, getting woken up. There's been periods where I get on the train at 3 o'clock in the afternoon and I get woken up at 1 in the morning trying to get off the train. So it's no fun, you know what I mean? It's just not the high that I like. Another consequence was loss of memory. Yes, forgetting stuff, forgetting where I put things, losing time and not knowing what happened during that time, which is really scary. Now, there are positive consequences of using benzodiazepines as well for patients. Just simple little things like walking down the street would really bother my anxiety, and now I don't have that feeling anymore. I feel like I'm able to do normal things. It can help with drug cravings. Well, you want to look out a little bit more for people that are on Suboxone or methadone because they're addicts. And if they have too many panic attacks, the first thing they're going to think about, like I do, is using. Now, many participants spoke about misusing benzodiazepines when they initially started when they first were in their, illicit drug use phase. Did it boost the high of the opioids? Of course, it did. So when you use them both at the same time, one of the main reasons was when mixing the two, if you take the benzo before the opiate, it puts you into an instant nod. And they also spoke of misusing the benzodiazepines when they first started methadone treatment. I was taking them all at once whenever I was prescribed, and for the day, which I don't remember at the time when it was, but I would take them all at once. I was mixing them with the methadone. I wasn't taking them correctly, and now, I span them out throughout the day. So this person is talking about how eventually they got to the point where they were able to take them appropriately. And another person spoke about a benzodiazepine prescription as a privilege. When I finally earned my prescription for Klonopin, I took it as prescribed. I've always taken it as prescribed because there is no point. And yet, I'm not going to lie, when I first got it, I'm sure I screwed around at the very beginning. But the way I look at it now is, so many people would kill just to be able to have this prescription. So how does this all come together? Well, we developed a preliminary conceptual framework, and it starts with the process of recovery for someone with opioid use disorder. And we might conceive of this as starting with active illicit opioid use, then moving on to an initial opioid treatment phase with methadone or buprenorphine, where they often are still using illicit opioids sporadically. And then if the patient continues in treatment, a later, more stable opioid treatment phase. And what we found was that the motivations for benzodiazepine use appeared to change over the recovery process from less appropriate to more appropriate. So if someone is actively injecting heroin, they're usually trying to boost their high with the benzodiazepine. And when initially starting opioid agonist therapy, they might also be trying to get high from the benzo, but they also start to recognize that that medication might help treat their anxiety. And later, when they're more stable in treatment, they're much more likely to use that benzodiazepine to treat their anxiety. And likewise, consequences of benzo use appear to change over the recovery process. So fatal overdoses are more likely to occur when someone is combining benzodiazepines with illicit opioids, less likely when initiating opioid agonist therapy, and much less likely when someone's stable in opioid treatment. And the benefits of benzodiazepines in treating anxiety are more likely to be appreciated later in opioid treatment. So what we're suggesting is that the capacity of an individual to take benzodiazepines responsibly can improve over the course of their recovery. So I personally have made a transition from being a more conservative benzodiazepine prescriber to a more liberal one. Now, if you had asked me a few years ago whether I would prescribe a benzodiazepine to somebody who was getting methadone, who also had a past history of misusing benzodiazepines, I would say, of course not. It's ridiculous. But after studying this issue further, I really think we need to question whether this is the right approach. And I think treating this as a black and white issue, which many clinicians do, might be doing a disservice to our patients. So in conclusion, prescribing benzodiazepines has both risks and benefits in patients receiving opioid agonist therapy. Benzodiazepines should be considered as one potential treatment for anxiety, but it may be safer to treat patients with benzodiazepines when they're more stable in their opioid agonist therapy. Thank you very much.
Thank you. We have one question? John.
Ted, great presentation. I was struck by the question of what you described with the sort of progression in the more responsible use of benzodiazepine as reflecting what I think we often see in the way people handle methadone and buprenorphine, that in the early stages of treatment, they often struggle with how they're going to use it. And it may take months, if not years, for some people to then reach a point where they're using it in a responsible way. So I'm not sure that the drug itself matters. I mean, there's this pattern of how do I learn how to control my addiction and how do I learn how to be appropriate with the treatment.
Yeah, I think that's right. That's what the research seems to indicate. You know, it's that there's a critical period right when they're starting methadone treatment or buprenorphine treatment where they're kind of being introduced to the treatment system sometimes. They're getting their first prescription for benzodiazepines, and it's a risky time because I think that they have one foot, you know, still using and the other foot in treatment. And I think that the medication has the power to sort of tip the balance one way or the other. That's why I think we have to really keep a close eye on that patient group in particular.
Thank you very much.